Then there's a external examination. Size of trauma gives you an idea whether there was something even forcefully or there was an accident, whether he had a seizure, side of infections which might mimic poisoning, chronic of alcohol abuse or drug abuse. He might have injection sites, might be have the having size of vernix and all. Mental status, and then comes to the toxic. Okay, then that's how we come to the next part. Is what is a toxic? So it is a constellation of findings, either from a physical examination or from the assay testing, which may result from anything. So it won't give you an idea that this is the poison, but it will give you an idea that this is the class of poison it might belong. Okay. So let's say if you're talking about narcotics or sedative hypnotic drugs like barbiturates, alcohols, benzodiazepines, opioids. Uh, so patient will have some slurring of speech, hallucinations, confusion, might be comatose depending on the dose administered, might have some CO2 narcosis due to respiratory depression, shock, and due to the above factors, pupillary dilatation or constriction will come later, which has which, vision blurring, dryness of the mouth, decreased temperature, staggering the work. So this can give you an idea that the patient is intoxicated, more maybe with a sedative or a narcotic agent. We are talking about drugs which are sympathomimetic. Okay? Drugs like amphetamines, drugs like cocaine, which give a kick, increase the sympathetic activity. These are sympathomimetic drugs. So if you remember your college time pharmacology and physiology, you can relate to it that whatever is triggered by the sympathetic system, just increase it by multiple times. The patient will be having increased temperature. He will be excited. Will be tachycardia, will be tachypnea. Okay, you remember the fight and flight response. So this is the fight and flight response. The ideally it is made so that the patient is able to run from a dangerous situation. But if you give medication and which increases adrenaline rush, you get all this diaphoresis, madrasis, nausea, vomiting, hypertension, and increased bowel sounds. And as I said, amphetamines, methamphetamines, ephedrines, pseudoephedrines, available cough syrups and all, phenpluramine, all this can be a sympathomimetic topic. This is from the head to toe. If you see Medvarsity, diaphoresis, hypothermia, hypertension, tachycardia, tachypnea, and increased loss. And anticholinergic. Okay, so opposite to sympathetic is parasympathetic or cholinergic. So it doesn't mean if you block the cholinergic, you get a sympathetic. We differentiate it with a dry skin or a diffuse bowel sounds. If your skin is dry, don't think it's symptom with all the other things that can be common. Okay. Generally, we don't give beta blockers here because then you have an unopposed alpha receptor stimulation and that leads to severe delinquency in blood pressure and heart rates. If you talk about the cholinergic, so this is the sympathetic system. Now this is the parasympathetic system. In college, we used to read, the dumbbells, diarrhea, diaphoresis, decreased blood pressure, urination. This is all parasympathetic. Meiosis, increased secretion, bronchuria, bronchospasm. Just remember, all of us must have seen OP poisoning. So this is a typical of OP poisoning. Bradycardia, excitation of skeletal muscles, hyperlacrimation, salivation, and sleep. So OPs, carbamates, insecticides which have OPs and carbamates, nerve agents like serine and all, and anticholinergic inhibitors, which decrease the level of anticholinergic agents. Okay. Sludge is another one that you can, or if you can remember this picture, this is what we have. So this was cholinergic. If we block it with medications like atropine, antihistamines, and the Turinol, we have an anticholinergic toxin. So hyperthermia, just like this. So dushman ka dushman dost. So opposite to symptomatic is cholinergic. Opposite to cholinergic, blocker of cholinergic will resemble some of these things, except a couple of things which I will highlight. So dilated pupils, but here they will be dry. Okay, remember, hot as a desert, dry as a bone, red as a beet, hot as a hair, blind as a bat, mad as a hat. Okay, so the patient will be agitated, mad as a hatter. He will have dilated pupils, will be difficult to see in light, blind as a bat, Hot as a hair because of hypothermia, red as a beet because of vasodilatation, dry as a bone because of sweating. This is a thing that we see. Then we have serotonergic toxidromes or SSRIs that we use. Again, a lot of things will be overlapping with the anticholinergic toxidrome. We'll have tachycardia, hypertension, hypothermia, confusion, agitation, lethargy, hydrasis, diaphoresis, flushed face, hyperreflexia, tremors, nausea, and rigidity. You might not be able to remember it all. So, and there's no shame in admitting that. So that's why whenever a patient comes, we take out our phones or we take out our toxidrome charts that we have and we tick. So the important is to know that you have a system where you can uh, feel this, refer to in case of an emergency. Okay, so agents like myoinhibitors, SSRIs, antidepressants, lithium, cocaine, methamphetamines, these individually or in combination can lead to this, what we call as serotonin syndrome. Mental status, autonomic instability, GI instability, neuromotor man. Okay. Then we have a toxidrome of opioids. So we have sympathetic agents, we have cholinergic agents, we have anticholinergic agents, and the similar sounding serotonin syndrome. Then we have an opioid. So just remember what an opioid does. So it can lead to coma if you go from head to toe, convulsions, hypertension, bradycardia, really tachycardia, urinary tension because of the cholinergic action, the hyperkalemia, bradypnea, cyanosis, pulmonary edema, respiratory depression, and myositis. So fentanyl or morphine addicts, which is OD, is how we live. Treatment, here we do have antidote like naloxone. So the supportive measure will be the same as we discussed. Within 1 hour, you can give charcoal though, apart from maintaining the airway and ventilation. Naloxone will be able to reverse a lot of these except buprenorphine. And this is the mostly we give 1 to 2 milligram IV and repeat 2 milligram up till 10 milligram after every couple of months. This is what is most commonly available with us. Other naltrexone and machine is hard to come by. Then supportive medication like physostigmine, again hard to come by, benzodiazepines and fluids. This is all support therapy, but we do have an antidote by the name of naloxone. Other will be de-addiction, mostly in de-addiction centers or patients. Sometimes we have patients coming with an unrelated disease, he's an opioid addict, and obviously you are not giving anything resembling an opioid in the wards, and the patient might end up in an opioid withdrawal. And you might confuse, okay, he seems to have an abdominal problem, an acute abdomen. It's very difficult to diagnose unless you know that the patient is an addict and he's not getting opioids. So sweating, mydriasis, so opposite of the body, tachycardia, goosebumps, these sympathetic activations, abdominal pain, cramps, muscle cramps, and leg movements, diarrhea, urinary incontinence, and vomiting. So a lot of symptoms are opposite to what we see in opioid toxicity. So I accept you won't be able to remember everything. My idea is also not to make sure that you remember everything. It's an idea to tell you that there's something by the name of this which you can refer to as soon as you see a patient, so you can take the boxes. Okay, don't try and remember everything. Just running through, but that's not the idea. Just understand the concept. Then we have EPS when we give like tranquilizers, perinorm, and all. So we have an extrapyramidal syndrome which has dysphagia, dysphonia, basically hyperexcitation, corticolis, langospasm, trismus, oculogyric crisis, lingual confusion, and all this. So these are EPS that we have, might especially seen in females, elderly females. There's even drugs like perinorm.